This recording deals with the discussion of the pleura, compliance, respiratory muscles, all of this in preparation for the discussion of the topic ventilation. And so the goal is to cover the physiology of ventilation. But before we understand the details of ventilation, we need to fill in some more details. Those are the ones that we will be looking at. Those are pleura, and then the muscles of respiration, as well as compliance. All right. What is pleura? It's the covering of the lung. Covering of the lung is a sheet that is organized into actually two layers. Inner visceral pleura, that's shown here. Inner visceral pleura, this one here, this is all lung tissue, visceral pleura here. Then the outer layer, the parietal pleura. There is a thin space between the two called pleural cavity. Pleural cavity is the one that contains a small amount of fluid. This fluid is a lubricant that helps separate the two layers, especially when they come close to one another. All right, so the slippery texture the fluid provides helps the inner visceral pleura to separate easily from the parietal pleura. Pleurisy is when there is inflammation of the pleura that could lead to a buildup of fluid in this space, and that would restrict the expansion of the lungs and therefore respiratory issues. In any case, so that is pleura. And now we talk about intrapleural pressure that is in association with the discussion of ventilation. Intrapleural pressure is the pressure that you find within the pleura. This is always going to be below the atmospheric pressure. If atmospheric pressure is 760, typically the intrapleural pressure is 756, 757, around there. Now, what happens is during inspiration and expiration, the pressure within the pleura fluctuates, but always below atmospheric pressure. Okay, so this is what you call as negative pressure. Negative pressure is anything that's below atmospheric pressure. All right, it could also be called as subatmospheric pressure. So those are different ways to describe the pressure that is in the pleura. So with this knowledge, we will take a look at the other topic, that is compliance. Compliance is the stretching nature of the lungs. Okay, it can expand and recoil. All right, it's a natural phenomenon. That's because lung tissue is equipped with elastic fibers. And there is another factor that contributes to compliance, that is the surface tension. Surface tension is the tension or the force created by the attraction between water molecules, the fluid lining the alveolus, where water having the two charges, a positive and negative, would be attracted to other water molecules nearby, and that generates what we call a surface tension. All right, so that again can contribute to compliance. If there is increased surface tension, then there is collapsing of the lungs. We talked about surface tension already. Surfactant is where the surface tension is minimized, and therefore the alveoli can remain open. All right. Compliance can be affected by a number of factors. Volume within the lung. Okay, if it's already expanded, it cannot stretch any further. So inspiration, when the lungs are filled with air, the lungs are expanded already. All right. So further expansion may not be possible. On the other hand, during expiration, when air is leaving the lungs, you would have the capability to expand the lungs further. That is greater compliance during the time when the lungs are less filled than when they are filled with air more during inspiration. So that's the relationship here. Posture can also affect the compliance. In the standing position, lungs can expand more because the diaphragm can move down the abdominal cavity further than in a lying position. So that is where the posture can affect compliance. Pulmonary blood volume. The volume of blood being greater than normal can interfere with the compliance. Less compliance when there is greater volume of blood than normal, and vice versa, right? Then the restriction of chest expansion. What could restrict chest expansion? Well, let's think about pulmonary fibrosis. Okay, elastic tissue replaced by fibrous tissue. That would minimize the ability of the lungs to expand. It would restrict the lungs from expanding. First of all, it's the loss of elasticity. Secondly, fibrous tissue makes the lung tissue stiffer, and it cannot expand as well as before. Asthma is when you have the bronchoconstriction. Okay, so the resistance there would make less air leave the lungs. So that could be increased pressure, and that could make the lungs compliance to be reduced. So these are some factors that could affect compliance. Now let's talk about respiratory muscles. We have one important muscle that plays a major role in respiration, that is the diaphragm. Okay, diaphragm is in a curved position in the upright posture, and then it would push down into the abdominal cavity, expanding the chest cavity during inspiration, and pull itself upwards, reducing the thoracic cavity space. And that is the kind of movement that affects the volume and then therefore affects pressure. We know Boyle's law at this point, so we can relate the movement of the diaphragm to the pressure changes, volume changes. All right. So diaphragm during inspiration would be moving into the abdominal cavity, increasing the space within the thoracic cavity, dropping the pressure below atmospheric pressure. So air can move in. By the way, I am assuming that you already know that any gas moves from higher to lower pressure, and when anytime the pressure drops, air would move into the lungs. All right, and during expiration, diaphragm shifts its position back to its original location, that's into the thoracic cavity, now the space in the thoracic cavity is minimized, and therefore the pressure would be greater within the thoracic cavity. That is, when air moves from the lungs to the atmosphere. All right, so something about neuromuscular blockade. You know, you are always focusing on neuromuscular blockade in situations of anesthetizing patients. And I would like to emphasize the fact here that diaphragm is not as easy to be responding to the neuromuscular blockade, more resistant than most other muscles. Why? Well, it's packed with acetylcholine receptors. It's exposed to loads of acetylcholine. So stimulation of the muscle because of acetylcholine mediated response is going to be great, and therefore the neuromuscular blockade would take more work at the diaphragm than elsewhere. All right, so now let's also talk about the speed. Okay, once you are able to make the diaphragm respond to neuromuscular blockade, it's rather quick. All right, that's because of a rich blood supply to this muscle. Now, yet another set of inspiratory muscles are external intercostal muscles. Okay, as the name suggests, these are like the outer layer of muscles and around the chest, and as they contract, they pull the chest cavity outwards, expand them, and therefore increase the volume. Increasing the volume of the chest cavity, as you know, decreases the pressure, correct? And that's going to help air move into the lungs. Okay, so the combination of the diaphragm and the external intercostal muscle contraction is what is involved in inspiration. There are a number of other muscles around the chest area, as well as the abdominal muscles, that play a part in respiration. Instead of naming every single muscle here, it's kind of summarized as one name: accessory muscles. They play minor roles compared to the diaphragm and the external intercostal muscles. You may think about quiet breathing versus forced breathing or deep breathing. So in quiet breathing is just plain normal breathing that you don't typically pay attention to every day. It's the breathing that happens automatically. And that's where you think about the diaphragm and external intercostal muscles being activated to contract during inspiration. And the passive nature of these muscles, meaning they're not contracting during expiration, the relaxation of these muscles simply allow expiration to happen. However, during forced breathing, air has to be forced out of the lungs. Okay, in order to do that, you may use another set of muscles that would make the chest cavity narrower and decrease the volume so that the pressure goes above and beyond normal thoracic pressure. So that is where you may want to think about internal intercostal muscles. Internal intercostal muscles, as they contract, would decrease the thoracic volume and increase the pressure. So it's the opposite of external intercostal muscle action. So neurointercostal muscles are used in forced breathing, but not in regular quiet breathing. Okay, so now we are going to discuss a few more details here. Force of muscle contraction has to overcome the resistance that exists in the airway and within the lungs. So the resistance is basically the opposing force. Okay, the size of the airway, like bronchoconstriction, could be one thing. Narrow airway would require more force to bring about inspiration. All right, and then we are also talking about resistance due to surface tension within the alveoli. All right, so all of those have to be overcome through muscle contraction to make air move in or out. And that's typically easily handled by the muscles of respiration. So the basic details of the muscles here, these are inspiratory muscles we're talking about, including diaphragm and external intercostal muscles. They increase the chest cavity volume, and therefore pressure would drop and air moves down its pressure gradient from the mouth into the lungs. All right, so that is how the muscles function. Now, literal details of ventilation. Ventilation could also be called as external breathing, meaning gas exchange is from the atmosphere into the lungs and from the lungs into the atmosphere. So air is brought in to the lungs or released back into the atmosphere. So that is ventilation. So it's automatically organized into two parts: inspiration or inhalation, then expiration or exhalation. Inspiration, as the name suggests, deals with the incoming air. Expiration, as the name suggests, releases air out into the atmosphere. As we discussed, inspiration requires the activation of inspiratory muscles. The activation of inspiratory muscles leads to muscle contraction. Muscle contraction is the one that allows inspiration to occur. And that's why we call it as an active process. And the pressure during inspiration is going to be below atmospheric pressure, subatmospheric pressure. All right. Now, it's the exact opposite during expiration. Air has to move out, and here the muscles relax. The inspiratory muscles, diaphragm and external intercostal muscles, relax. So it's not an active process. Instead, we give a new name. It's a passive process. It's not energy dependent. That's what it means. All right, it's a passive process. Pressure would be slightly greater than the atmospheric pressure. If we were to make up some numbers, we could think about 760 as the atmospheric pressure at sea level. Subatmospheric pressure is below atmospheric pressure. So let's call this as like -2. So that is 758. And then during expiration, we could switch this to 762. That's +2. Okay, so it's greater than atmospheric pressure. Now, we need to deal with a number of different pressures during ventilation. All right, we already talked about atmospheric pressure. Well, then the pressures within the chest cavity could be organized into intrapleural pressure and intrapulmonary pressure. intrapleural pressure is also discussed already, the pressure that exists at the pleura. It's always going to be subatmospheric. All right. So whenever the muscles contract, volume expands, the intrapleural pressure acts like a suction, vacuum. Now it pulls the lung tissue to expand outwards. So that's how the intrapulmonary volume increases. All right. When the muscles contract, it's all around the chest. So first the change is at the chest, then the intrapleural pressure pulls the lung tissue outwards to make the volume within the lungs expand and the pressure drop. So it's the action of the pleura that creates this new situation where the pressure within the lungs would drop. Now, intrapulmonary pressure is one way to call the pressure within the lungs, or the alveolar pressure. Okay, one and the same. All right. Both intrapleural pressure and intrapulmonary pressure change depending upon the event within ventilation. If it's inspiration, pressures here drop. If it's expiration, pressures here go up. But you already know that intrapleural pressure is always going to be subatmospheric in a normal condition, and intrapulmonary pressure could be slightly above atmospheric pressure during expiration. Now, what is transpulmonary pressure? It's simply the difference between the alveolar and the intrapleural pressure. Okay, so the difference is typically about the same. So let's think about inspiration. I'm going to make up some numbers. When it's inspiration, let's think about intraalveolar pressure as 758 and intrapleural pressure as 754. So it's going to be a difference of 4. 758 minus 754. So that's what the transpulmonary pressure is. During expiration, let's make up some new numbers. Let's think about the pressure, alveolar pressure, to be 762. Okay, so this is a new number, 762 within the lungs. What about the intrapleural pressure? Remember, it's subatmospheric, so its pressure is going to be 758. So in this new situation, 762 minus 758 is still going to be a difference of 4. So that is the kind of pressure we maintain between the alveolar and the pleural pressures. That is what we call as transpulmonary pressure. Good. All these are simply essential in understanding what happens during inspiration. Here is the atmospheric pressure, P atmospheric, and here is the P alveolar pressure. What we see here is 760 inside, and let's assume that 760 millimeter mercury is the atmospheric pressure. If the pressure between the inside and the outside is the same, okay, that's a situation you see in a resting period. All right, so it's not like the lungs would rest forever. It's just that a brief pause between inspiration and expiration. So whenever the pressure within the lungs matches the pressure in the atmosphere, there is no gas exchange. So the arrow is not going in, not going out. So it's just called resting situation. Okay. And now during inspiration, what's happening? You could see the size of the the lung, it has expanded, right? It has expanded. And the chest, the green line is supposed to be the chest cavity, the black line is supposed to be the lung, and now the space here is the area into which the lungs would expand into. So the expansion of the lungs decreased alveolar pressure. So it's not 760. It's left to your imagination here. So we could call it negative 2. And that's when the air from the outside would move into the lungs. So this is inspiration. Okay, it says here, drop in pleural pressure, drop in alveolar pressure, and that allows inspiration or inhalation. And the opposite is true for expiration. And here we have a step-by-step event. Respiratory muscle contraction is shown, one here, so the expansion of the chest cavity, and then 2 would be increased increased intrapleural pressure is intrapleural volume. Yes, increased intrapleural volume, decreased intrapleural pressure. Okay, the blue line is showing drop in pressure. Okay, so now that leads to increased alveolar volume, green here, and then decreased alveolar and intrapleural pressure, that is shown in blue. Okay, so drop in pressure, increase in volume, and now air would move in. So it's simple illustration to show the direction of the movement of the diaphragm, diaphragm moving down, and external intercostal muscles moving outwards, allowing the expansion of the pleura, expansion of the lungs, therefore the volume expansion, therefore the pressure drop, and then the air moving in would be number 5, air moves in. All right, so with that, we could switch to expiration, where you would see the muscle relaxation. Now the external intercostal muscles would go back inwards, and same is true of the diaphragm. So the two together makes the volume drop, pressure increase, and then the air moves out. All right, so that's where we stop, and we will discuss other details elsewhere. Thank you.